طيب، بسم الله والصلاة والسلام على رسول الله محمد بن عبد الله سيد الأولين والآخرين وعلى آله وصحبه أجمعين. اللهم لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. أما بعد، تحية طيبة يقدمها لكم فريق خدمات الأشعة بالتجمع الصحي بمكة المكرمة بقيادة سعادة الدكتور ماهر بن عبد الرحيم غزاوي، وبدعم ومساندة المدير التنفيذي للخدمات الطبية المساندة سعادة الدكتور فهد نوار الحارثي. فالسلام عليكم ورحمة الله وبركاته. حياكم الله جميعا في هذا اللقاء المبارك الذي سيكون فيه معنا سعادة الدكتور حسين سالم برد، أخصائي أشعة بمستشفى قليص العام التابع للتجمع الصحي بمكة المكرمة، وذلك لتقديم محاضرة بعنوان برين تروما. بسم الله وعلى بركة الله نبدأ. تفضل دكتور حسين.
السلام عليكم ورحمة الله وبركاته. معكم الدكتور حسين. I am Dr. Hussein Salim Muhammad, MD Senior Radiologist, Senior Diagnostic Radiology, Mecca Health Cluster, Saudi Arabia, in Khulwas General Hospital. Inshallah, today we will discuss brain trauma. Bismillah. About the lecture, due to the high rate of the road traffic accident and the trauma cases, this lecture will focus on covering essential brain trauma finding to help emergency physicians. Practice example and key reporting tips will be discussed to minimize diagnostic error and improve patient care. The objectives of this lecture to identify the common types of brain trauma: extradural hematoma, subdural hematoma, contusion, diffuse axonal brain injury. The highlight critical CT science for the brain hemorrhage detection. Discuss optimal imaging protocols in emergency setting. Clarify essential points to include the radiology report. The aim to understand indications and select the appropriate imaging modality to identify common traumatic emergency abnormalities of the brain to determine an immediate life-threatening abnormality on an CNS imaging. The introduction: head trauma is the leading cause of death in people under the age of 30. Male have 2 to 3 times frequency of brain injury than females, due mainly to motor vehicles accidents and assaults that mean case fighting. We receive in ER daily a lot of fighting cases with head trauma and different trauma in the body. Outline classification of the trauma brain injury, clinical indication for imaging technique, extra-axial hemorrhage, intra-axial injury. The classification of traumatic brain injury: primary and secondary mechanism of injury, penetrating, blunt, location, intra-axial, extra-axial. The clinical severity depends on the glaucoma scale of the patient, classified as mild, moderate, and severe glaucoma scale. This is important in management of the patient in neurosurgery if this patient needs intervention surgery as evacuation of the hematoma or no, depending on the clinical glaucoma scale and depending on your imaging as CT brain, as you know later. Classification of traumatic brain injury: primary versus secondary. The primary injury starting from the scalp may has wound or blunt trauma like blunt trauma, hematoma collected beneath the scalp like subdural hematoma, skull fracture of different types. We will discuss it. Surface contusion laceration, intracranial hematoma, diffuse axonal brain injury, and diffuse vascular injury also. The secondary, hypoxia, ischemia, swelling, brain edema, raised intracranial pressure, meningitis, may be also abscess collection in the brain. Category and key points. We starting with the mechanism. Mechanism: blunt, high velocity, low velocity, fall, assault as fighting, penetrating, gunshot wound, stab wounds, blast, explosive devices. The severity dependent on the Glasgow scale: mild starting from 13 to 15, moderate 9 to 12, severe 3 to 8. It is very important for management in neurosurgery of your patient of trauma head. Morphology: the skull, fault, linear, still late, depressed, non-depressed, open, close, basilar plus or minus, cerebral spine fluid leak or plus minus, cranial nerve palsy. Morphology of the brain: focal like epidural hematoma, subdural hematoma, or diffuse like brain contusion, concussion of the brain, diffuse axonal injury of the brain. We will talk about it later. Imaging modality: plain radiograph starting initially in the AR, after that following by ultrasound in the children, or CT in the children also, or in the adult. MRI, we need it in some setting of brain trauma like diffuse axonal injury when the CT brain normal but patient comatose in ER after trauma. So we need the MRI, especially the protocol of WSI showing blooming artifact. We will talk about it. Radio nuclei also study, and angiography. This is the modality. We're starting with conventional X-ray, use a form of ionized radiation, as you know, good in evaluating air-containing structure, bones, and calcification. The limitation of the conventional X-ray: no deformation, loss of tissue, contrast, also radiation exposure to the patient. We're starting in DR, ER with ultrasound in neonate trauma, or for any anomalies or suspected intracranial hemorrhage in the neonate or adult child. This is probe of ultrasound put probe both in the anterofontanel or posterior or in to see this examination: transcranial ultrasound, sensitive in evaluating soft tissue and fluid containing structure, CNS application in antenatal fetal imaging, infants, also in young children. This normal ultrasound as example to how to see the ultrasound imaging. This is the coronal, this anatomy. This is the third ventricle, right lateral ventricle, corpus callosum. As you see, this is the anterior part. This is the posterior fossa. This is the medulla oblongata, hippocampus, brain stem. This is normal appearance to see and put it in your mind to know. If you know the normal, you also detect the abnormality. This is the sagittal and this is the coronal. The coronal, this is the third ventricle, normal also, and this is the choroid plexus in the lateral ventricles. This coronal view. The sagittal view is important also in congenital malformation if there is any abnormality in the corpus callosum, as agenesis partially or complete absent of the corpus callosum. The corpus callosum in this sagittal normal, this is the rostrum genu body, and the last part in the posterior aspect of the corpus callosum, the splenium. Above the corpus callosum, this is the cingulate gyrus. The aim from this imaging to detect, to see the normal. If any abnormality like hemorrhage, you can detect it. We will talk about the abnormality intracranial hemorrhage in infant with ultrasound study in later. Computer tomography, this is the machine of the CT scan. This is the gantry, and this is the table patient put here, and sliding the table in the uh, gantry. The gantry, there is multiple detectors surrounding and circling around the head of the patient. This is view about the machine of CT scan. CT scan using ionized radiation like X-ray also, but this it is important in some cases. In a lot of cases like trauma, like RTA, tumors, so CT is the best choice in the beginning to rule out any head or brain trauma. Cross-sectional imaging principle based on differential X-ray beam attenuation by tissue imaging contrast displays as scale density attenuation. When you see low attenuation that is dark in the CT, like CSF, like air, like fat in the brain, high attenuation, white like bone, calcification or hemorrhage, but different in the density. HU Hounsfield unit, different between them in the reading. Approach to CT brain, look at the scout film. Why? To detect if query fracture of upper cervical spine, skull. Look, you have to look bone windows to see. Important to look for bone window to see fractures of the skull, base, maxillofacial, anything. Look for brain asymmetry in the brain tissue. Look at the sulci Sylvian fissure and system to exclude subarachnoid spaces hemorrhage. Look for the subdural collection. Determine if mass is intra-axial in the brain or extra-axial out of the brain parenchyma. The advantage of CT, high sensitivity for calcification, as mentioned, easier and faster to perform, most sensitive for detection of acute hemorrhage, increasing availability, no contraindications to emergency patient scanning, quickest and most efficient screening technique in acute trauma setting. Disadvantage of CT, high radiation dose, as mentioned, per examination. Children also, you can expose your patient with ban CT in trauma, so patient exposed for more radiation, but it is mandatory, so it is emergency or urgent case. Children are more sensitive to radiation-induced cancer than adults. Bone marrow, thyroid, breast, lung are the greatest risk. Contrast-related side effect also hazard or more increase more radiation to the patient dose of radiation. Factor to consider when determining need of CT in patient with head injury. Indication for urgent CT scan include the evidence of skull fracture, based breast or open fracture, abnormal result of neurological examination, seizure, vomiting more than one time, high risk mechanism like ejection from vehicles or pedestrian or cyclist versus automobile, decreasing glaucoma scale score. It is important. Clinically persistently decreased glaucoma score of less than 15. It is indication for CT scan for the patient. Indication of lower threshold for CT include age more than 60 years old, persistent antegrade amnesia, retrograde amnesia, amnesia more than 30 minutes, coagulopathy, fall from 5 stairs or more than 3 feet. Intoxication, examination, unreliable, loss of consciousness more than 30 minutes, also mechanism and location of injury, social factor like abuse, situation at home, language barriers, preload, accurate history, all this is in lower threshold indication of CT. The magnetic resonance imaging MRI use a strong magnetic field and radio frequency pulses, excellent soft tissue contrast, multiplanar imaging capability, no ionized radiation in MRI, also ultrasound and MRI, no ionized radiation. The ionized radiation in X-ray and CT scan. This for the resident, if any resident now attend in this lecture for more benefit. The advantage of MRI use non-ionizing radiation, less invasive technique, multiplanar capability, excellent soft tissue contrast in MRI and whole body, ability to depict flowing blood without need of IV contrast administration like CT scan. CT scan in the trauma, no need. In CT brain, no need contrast. If both contrast, it is depict with the hemorrhage. So any CT, any plane of CT in the ER post-traumatic without contrast. Disadvantage of MRI, cost, limited availability, length of the examination time, physiological motion artifact, acoustic noise. Contraindication of MRI, ferrous object, oxygen tanks, wheelchairs in the scan room, extremely dangerous. Patient with electrically or magnetically activated implants, cardiac pacemaker, implanted defibrillators, patient with the intracranial aneurysm clips, or patient with metal within the eye, or some decorative tattoos. For this patient of intracranial aneurysm clips or eye metallic as artificial eye globe, if it's not take good history and both patient for MRI examination, maybe these clips move should maybe move and causing laceration or injury in the brain and causing intracranial hemorrhage, intrabronchial hemorrhage. Indication for CT MRI scanning of the brain, general rules in the brain imaging, acute neurological illness starting with CT, subacute chronic starting with MRI. MRI is the imaging study of choice evaluating most brain abnormalities. Head CT is the first line modality for brain emergency. General rule, spine imaging, bone spine, CT, conventional radiograph, marrow replacing designate MRI, intervertebral disc MRI, CT, myelography, content, spinal cord, nerve root, ligaments, MRI. So MRI is important in soft tissue and intervertebral disc. MRI is superior than CT. Classification of traumatic brain injury, intra-axial versus intra-axial. Extra-axial injury, skull fracture, epidural hematoma, subdural hematoma, subarachnoid hemorrhage. Extra-axial injury, skull fracture, we're starting with the skull fracture, no predictive of the intracranial injury. Absence doesn't exclude intracranial injury. Type, linear fracture, depressed fracture, basal, comminuted fracture. Risks of brain injury increase with the depth of depression. Plain X-rays, CT scan, standard modality for aiding the diagnosis of skull fracture, helical CT scan, help occipital condyle fracture, but 3D reconstruction usually not necessary in this situation. MRI and MRI is value of suspected ligamentous and vascular injuries. Bone injury are the far better visualized using CT. CT is better in bones than MRI. MRI better in soft tissue and ligament, also in intervertebral disc than CT scan. X-ray, this is the linear fracture, lucent, sharply defined without sclerotic margin, mimic vascular groove suture. This is lucent lucent, sharp, defined without sclerotic margin. This is the key bit for mimic vascular groove or suture. But we can differentiate between the fracture line and the skull suture by the skull suture sclerotic edge, but the fracture line sharp lucency like this. So you can differentiate between them on the skull fault. The breast fracture increase or double density seen on X-ray like this, double density, best evaluated by CT, 5 millimeter depression elevation indicated. This is sagittal bone window CT scan showing more clear the breast fracture than the X-ray. This is a different patient for the breast fracture, as you see. Also, this is a different patient for the breast fracture in different site in the skull. This is selected cut of CT bone, CT soft tissue window showing the breast fracture causing compression on the beneath brain parenchyma with hemorrhagic contusion in the left frontal and causing compression at the adjacent brain parenchyma and midline shift to the right, mild midline shift to the right side and compress the ipsilateral lateral ventricle. The bone window selected cut of not the same. This is other case on the right frontal, the breast fracture showing also compress the adjacent brain parenchyma, but not seen in this bone window. You can you do should be do brain or soft tissue window to see the brain parenchyma as this case. This is a subdural hematoma also seen clearly in the soft tissue or brain window. This is 3D. Should you have to do 3D in any traumatic patient to visualize or more determine the fracture. This is the breast fracture seen obviously in the 3D. Bing bong, the breast fracture, this relative to the child only. This fall down on his head. This is the gross, and this is bone window showing the breast fracture in the high brighter region. In the 3D, it is the breast fracture, but no any linear or any comminuted fracture, just bing bong, the breast fracture as the ball. We talk about anatomy of the meninges briefly. This is the outer layer of the dura. This is inner layer. Also, this is the arachnoid. This is the subarachnoid space. And this is the biomatter covering the brain parenchyma. Localization of hemorrhage in this gross CT, and this gross image. This is the epidural between the dura and the inner table of the skull, and this is contusion noted in the right left frontal lobe of the brain. This subdural hematoma noted. Also, this subarachnoid in smearing of blood in the CSF spaces. Diffuse axonal injury in the intervention or the gray-white matter junction. Extra-axial hemorrhage, intracranial and extracerebral, epidural hematoma, contusion, subdural as mentioned. We talk about it one. This traumatic hemorrhage, also we talk about the epidural space, subdural space. Also, this is the outer layer of the dura. This is the inner layer, the arachnoid, and biomatter, which covering the brain parenchyma. Traumatic hemorrhage, we starting with the epidural hematoma, and epidural hematoma is bleeding that occurs between the dura and the skull, mostly seen in children who have head injury with fracture of the temporal bone resulting in tearing middle meningeal artery. In theory, epidural hematoma can cross the midline because it is located between the dura and the inner table of the skull. However, since the dura is tightly adherent to the adjacent skull near the suture lines, so epidural hematoma usually doesn't cross suture lines. Even there is diastasis of the suture, it can pass or cross or fracture in the suture. Now we talk about epidural hematoma. On blood collection we say within the potential space between the skull inner table and dura mater, 75% at the tumbral region, usually 99% at the cup side. Majority have skull fracture, 85 to 95% in children, often absent. Mostly arterial bleed due to laceration of the middle meningeal artery or dural veins. Expand, present rapidly, tense, distension causing. The radiological signs of epidural hematoma: biconvex or lens with sharply defined margin, doesn't cross sutures as I mentioned, like unless there is fracture or the stasis of the suture line. Mass effect, plus or minus brain herniation, displacement of the sinus of ax cerebri of the skull from the skull, adjacent skull fracture. This is a selected cut of the brain at the level of lateral ventricle, showing extra or epidural hematoma, biconvex or lens shape, hyperdense, extra-axial collection, doesn't cross the suture lines, showing abnormal density. Hyperdense, within it, there is hypodense. This is swear sign. It is called swear sign. The hyperdense is the acute bleeding, but the hypodense, it is the active bleeding. Also, this hyperdense biconvex epidural hematoma in the left tumbral region. Extradural hemorrhage also in different patients by different appearance, hyperdense homogeneously compress the adjacent brain parenchyma. Some of them associated with the fracture, some of them not associated. Different density associated with midline shift, brain edema adjacent or effacement, the adjacent brain parenchyma to the epidural collection. The important in the epidural hematoma, what I do or what I write in the report. This is very important. Some of doctor maybe miss this information. The epidural hematoma, you should be measure the volume. How to measure the volume of the epidural hematoma? You measure by 3 diameter. The length, take the length and put A for the length and width B. When take the length line, put perpendicular line from the bone on the A line as vertical line. This is B, measure the width. The A measurement 6.3 cm. B 2.7 cm. We need to measure the depth. The depth is the C. Okay. Depth the C. How we calculate the C or the depth to measure the volume? I will show you real case. See the screen. This is the case how to measure the volume of epidural hematoma. This is the length from here to here by line A. Line B perpendicular from the bone to the A line. And put the measure in centimeter. What about C? C, we starting from the last cut. We starting from the last cut of the hematoma. This is the last cut here. And count the slices. 1, 2, 3, 4. I count about the last cut disappear the hematoma. It is about 52 millimeter. Okay. So now we have three parameters A, B, C. The slice thickness of the CT 1 millimeter. We should measure by centimeter. We change the millimeter to from 1 milli divided on 10 cm. So it is 0.1 cm. Multiply 1 point slice with C diameter, that is 15.2. So it is 5.2. So 5 or 5.3 when we change the parameter from millimeter to centimeter. So we have three parameters: length A, B, width B, and C. We multiplied all A by B by C and divided the result on 2. So the result is the volume. Volume by cubic centimeter. This is the best measurement of the epidural hematoma, and put it in the report. Why? Now you know this information is important in the management. The management of extradural hematoma, the extradural hematoma, more than if the extradural hematoma measure more than 30 cubic centimeter should be evacuated. So we put measurement for by volume, as you know, in the real in the screw ring case. Extradural hematoma less than 30 centimeter and less than 15 millimeter thickness and less than 5 millimeter midline shift, and the glaucoma scale less than 8 may be managed non-operative with serial CT evaluation and conservative management for this patient. So the measurement of extradural is very important to measure it and put the measurement in the report. After that, we talk about the subdural hematoma. Subdural hematoma is collection of blood between the inner layer of the dura and the arachnoid. It cannot cross the midline, but can located near the dural fold like falx or tuturan cerebelli. We put example with imaging on this case. Usually result from rupture of the cortical bridging veins, usually occurs due to head trauma, especially in patients who are treated with anticoagulation. Most common elderly and alcoholic patient with atrophy also exposed or may subdural hematoma occur. Brain atrophy have venous subdural structure less well packed against the skull, which gave them more space to move, possibly to turn. Subdural hematoma, we should summary about it between the dura and the arachnoid. Cross the suture, not cross the dural reflection. Don't disruption of the bread cortical due to disruption of the breathing cortical veins. Hyperdense acute, isodense subacute, hypodense chronic. The difficult of them is the iso, maybe miss iso to the brain parenchyma. The radiological signs of the subdural crescent shape, most common location are the frontal and parietal convexity, countercop. Unlike extradural hematoma, its spread is not limited by the suture lines. It can spread over the whole convexity. It is almost never cross the midline. Mass effect plus brain herniation, skull fracture in less than 50% of the cases. We have three selected cut of this patient in follow-up. This is the crescent shape extra-axial collection cross the lines but doesn't cross the midline. It is hyperdense, so it is acute. This is isodense to the brain parenchyma, so it is missed easily if you don't carefully to search, or you if you don't have history. And this is the chronic hypodense. In patient with subdural hematoma, midline shift patient was operated. This after operation, this is the whole operation or uh, craniotomy in this area. This is the hyperdense of subdural hematoma noted in the frontoparietal region with the slightly compressed adjacent parenchyma of the brain and causing effacement. And after operation, this appear no any collection noted because there is defect in the site of surgery. Subdural hematoma imaging, this the different cases, acute, hyperdense, isodense, that's subacute, chronic, this is the isodense, difficult. Sometimes this is bilateral also, difficult, but you, if you concentrate, you can get it. Isodense also bilateral. This is the in the right frontal, and this is in the parieto occipital region. Adjacent to the brain parenchyma, iso to the brain parenchyma, so it is difficult to detect it. Also, this is different imaging of the subdural hematoma. This is hyperdense with different egg. Also, this is hyperdense and hypodense, different egg. So some of them are hyperdense and acute and subacute, associated with mild hydrocephalus, as you know here in this yellow arrow. Chronic subdural hematoma noted in this case hypodense. So the hypodense in setting of trauma or a known case of in follow-up of subdural hematoma, after hematoma more than 20 days become hypodense to the parenchyma of the brain and iso to the CSF. When is iso to CSF or hypo in comparison to the brain parenchyma, I guess it is uh, chronic subdural according to the duration and according to the density. Hygroma also resulting of the traumatic turn in the arachnoid layers, which is causing CSF to leak to the subdural space in elderly patient. Also, subdural hematoma can appear or can see it in the false cerebri and tentorial cerebral line. Also, extra-axial hematoma or collection. This is the ideal report for traumatic non-enhanced CT traumatic patient in ER like this. The report, extra-axial collection, crescent shape, subdural hematoma along right or left according to your case. You put the density of this lesion, hypo or iso or hypodense, suggest acute, subacute, or chronic. Measure approximately thickness of the subdural hematoma. Also, the extending along the convexity, crossing suture but not crossing midline. Mass effect effacement adjacent to brain parenchyma, sulci like this. Ipsilateral ventricle, midline shift. If there is midline shift, you put the measurement with millimeter here toward the opposite side. Additional finding, this is the pertinent negative finding should be mentioned in the report. No or yes, no intraparenchymal hemorrhage, no skull fracture. Also comment on the basal cister, preserved or affected. This is the finding for this case. Thickness, the site of the hematoma collection, subdural hematoma on the right side, frontoparietal, crescent shape like this. You can put in your report. This acute thickness, 12, approximately 12 millimeter. Cross midline shaft, comment on the ventricle, comment on the if midline shaft, the cistern is affected or not. This cistern also affected. Brain parenchyma hemorrhage or no. The pertinent negative finding is very important to mention in your report. So finally, put your inversion, acute example, right acute subdural hematoma with the mass effect midline shift approximately 6 millimeter. The important your recommendation here for surgical consultation, neurosurgeon consultation. The management of the subdural hematoma, acute subdural hematoma within thickness. If the thickness, so I say the extradural hematoma, you should measure the volume and measure the midline shift and measure the thickness. Put it this measurement in the report for important for management of your patient. Also, the management of subdural hematoma, the important in your report to mention thickness of the collection more than millimeter or midline shift more than 5 millimeter should be evacuated. So measurement is very important mentioned in your report to save your patient, to help your patient, to help your the doctor that's managing this patient. Patient in the coma with decreased Glasgow scale by more or equal 2 points with a subdural hematoma should undergo surgical evacuation. Subarachnoid hemorrhage also important. The subarachnoid secondary to intracerebral hematoma due to traumatic shearing of an intracerebral artery with visible associated with arterial dissection. Prognosis depend on the extent of blood in subarachnoid space associated with degree of vasospasm. More blood in the prepontine cistern, graph to the outcome and depth of the coma. Obstructive hydrocephalus is an inevitable sequelae. CT modality of choice, MRI, flare, free, helpful. Subarachnoid hemorrhage, this is a selected cut CT at the level of the cortex. This is smear of hyperdense in the CSF space. So after trauma, so the diagnosis is subarachnoid hemorrhage. Subarachnoid hemorrhage, the image showing hyperdense blood in the subarachnoid spaces with Sylvius fissure also noted. Subgaleal hematoma noted in the occipital region. Not important, this for not important for conservative, but the important subarachnoid hemorrhage is important and urgent for life-saving this patient. Note subgaleal, okay, in the right side of the occipital region, and the counter type of injury also noted in this case. This is the smearing of blood in CSF spacing diagnosed subarachnoid hemorrhage. These different cases noted CT and MRI. This diffuse subarachnoid or hemorrhage in the CSF spaces noted in this case at the right side, and this case in the Sylvian fissure, the parietal and the surrounding the quadrigeminal cistern, also the in this area noted. In MRI also in the occipital region in the CSF spaces noted hyper intensity. Intraventricular hemorrhage also important extension, either extending from the intracerebral hematoma or resulting from shearing of the choroid plexus. Obstructive hydrocephalus is inevitable sequelae. CT is modality of choice. CT is modality of choice in all cases of head trauma and brain trauma. Intraventricular commonly or most commonly rupture subependymal vessels. can occur from the reflux of subarachnoid hemorrhage also. Contiguous extension of an extracerebral hemorrhage. Look for blood cerebrospinal fluid level in the occipital horns also. This example of intraventricular hemorrhage in the fourth ventricle, in the third ventricle, in the left lateral ventricle. These different regions noted on all ventricle, causing also dilatation or ventricomegaly or mild hydrocephalus. So this is example of intraventricular acute hemorrhage. Intraventricular hemorrhage also in this case noted in the lateral ventricle, extended and crossed the midline to the other lateral ventricle on the left side. So important to searching about all brain anterior, middle, and posterior fossa, to searching the source of maybe there is association with this case subarachnoid hemorrhage. We will talk about the intraventricular hemorrhage in children by pill classification. There is 4 grade by ultrasound. Grade 1 subependymal germinal matrix. We see the normal ultrasound in the beginning of the lecture. Now we applied the abnormal or pathological like hemorrhagic germinal matrix hemorrhage of the intracranial. Grade 1 subependymal germinal matrix hemorrhage limited to the caudothalamic groove. Grade 2, the same. Grade 1 with extension to the ventricular system, but without dilatation or without ventricomegaly. Grade 3, the same. Grade 1 plus grade 2 with dilatation in the ventricle. So grade 3 hemorrhage in the ventricular system with dilatation. Dilatation classified mild, moderate, or severe. F mild, grade 3 mild, moderate, grade B moderate, 3 F severe, grade 3 severe. Grade 4, the same, grade 1, 2, 3, with extension to the brain parenchyma, so it is grade 4. Grade 4. So this is the gradient applied on these cases of transcranial ultrasound. This grade 1 subependymal in the caudothalamic groove, grade 2 in the ventricle without dilatation, grade 3 in the ventricle with mild dilatation. So this is grade 3 type A or type B, mild to moderate. Grade 4, it is intraventricular and extension to the brain parenchyma. So it is important to know it if you do ultrasound transcranially for neonate. You should have this information. Extra-axial injury, surface contusion, laceration, intraparenchymal hematoma, diffuse axonal injury is important. Post-traumatic infection, brain stem injury also important. Surface contusion laceration, surface contusion laceration. Most common source of traumatic, most for traumatic patient, contusion most involve the superficial gray matter, laceration contusion plus tear of the bia-arachnoid affecting the crest of gyri. Hemorrhage is present in half of cases and occurs at the right angles of the cortical surface, located near the irregular bony contour, balls of the frontal lobes, temporal lobes, inferior cerebral hemisphere. Brain contusion when patient receive beating or trauma in the frontal, brain concussion moving from anterior to posterior. So this moving leading to contusion or axonal brain injury. Unaffected direct impacted on the site of trauma curb, diagonally across the contralateral side counter curb. The beating or the site of impacting in this side, the hemorrhage to the other side to this counter curb. Counter Cobb, counter Cobb, type of the injury with the contusional hemorrhage and subdural hematoma in left frontal lobe near the skull base. Also there is a subarachnoid hemorrhage on the right with fracture of the parietal bone. As you see, this is vertical linear fracture noted, non-displaced, associated. Beneath it, there is a contusion on the frontal lobe of the hemorrhagic contusion in the right frontal lobe, and there is also subgaleal hematoma noted. Contusion laceration of the brain. This example, this is hemorrhagic contusion in the left frontal, noted also with surrounding with edema and causing conversion on the adjacent or effacement of the adjacent brain parenchyma. This is bilateral frontal hemorrhagic contusion of the brain. As example, this is non-hemorrhagic brain contusion in T1 MRI, also noted. Intrabronchial hematoma, the same term is the intracerebral hemorrhage, the same term. This is the brain parenchyma hyperdense in the right tumbral legion as focal collection of the blood, common arise in the shear strain injury to the parenchyma vessels. Intrabronchial hemorrhage also noted in different area of the brain, in the frontal, in the occipital, and there is extension to the lateral ventricle bilaterally and in the fourth ventricle. This large pooling of hemorrhage noted intracerebrally in the right, in the left frontal intrabronchial region, frontal region, surrounding with massive edema and causing conversion on of the adjacent brain parenchyma and causing midline shift to the left side and compressed the ipsilateral left lateral ventricle. Diffuse axonal injury, this is the important item or important type of hematoma or brain injury. We talk about it speedily. High impacting trauma with acceleration or decelerations forces, especially rotational acceleration, can lead to stretching and the formation of the brain tissue, resulting in diffuse axonal injury of the brain. CT has no sensitivity for detecting diffuse axonal injury. So when patient coming to ER with trauma, brain, patient low of consciousness, unconscious patient, CT brain normal, no nothing in the brain. So patient referring your recommendation in the report, normal CT brain, no any acute injury or acute hemorrhage noted in the brain parenchyma. Patient for MRI, especially the sequence of WSI, showing blooming artifact. This is the role of MRI in this situation of brain trauma. Axonal injury, this is the axon covering by myelin sheath. When brain concussion and moving, there is leaking of the glutamate from the axon outside, causing hemorrhage or hyperdense like this case. This is diffuse axonal injury. CT sometimes detected as this case. Diffuse multiple foci or lesion in the brain parenchyma. Okay, this is the diffuse axonal injury noted in different area of the brain parenchyma and extending to the lateral ventricle, posterior horn of the lateral ventricle. This is good example of the diffuse axonal injury. So a lot of cases not seen in CT. CT is normal. Diffuse axonal injury due to acceleration, we said, and acceleration, white matter. There is three types of or three grade. Grade 1, axonal damage in the white matter only. about 67%. Grade 2 white matter plus corpus callosum at posterior aspect more than the anterior aspect, about 21%. Grade 3 white matter plus corpus callosum plus brain stem at the posterior aspect of the brain stem. MRI, WSI showing also we bought or request for MRI, WSI, diffusion, flare T2, so restricted diffusion in W, punctate, restricted diffusion lesions, WSI grading, blooming. This is important sequence in axonal brain injury. Blooming, micro bleed or micro hemorrhage noted in the brain parenchyma detected F1 dot. Diffuse axonal injury, this is examples. This is dot in the parenchyma and the gray white matter junction. The parenchyma, this is grade 1. Also, this is grade 1. This is noted in the brainstem. So it is the worsening grading, which grade bleeding or axonal noting in the brainstem. This is worsening and bad prognosis for your patient. MRI finding, this is accurate and clear. Any axonal brain injury noted in MRI, like blooming artifact in the cortex, in the white gray matter junction, distributed in the anterior, in the frontal, parietal, occipital, as you see. Post-traumatic infection, also important. Sometimes having for patient post-traumatic infection, hemorrhagic infection or non-hemorrhagic infection. Brain edema also important. You a lot of cases coming to ER, you see no differentiation between the gray white matter, or there is effacement of the sulci, or indicate generalized brain edema of the patient. This is CT selected cut of left axial, shows a hypodense right anterocerebral artery, midcerebral artery distribution, also posterocerebral artery infarction leading to hyperdense with bleeding. Brainstem also important. If any injury in the brainstem, it is causing detected in CT scan as hyperdense hemorrhage. We talk about briefly about the herniation, subfalcine herniation, like seen in this imaging. There is a falcine herniation to the left side. Descending herniation also noted in this case, medial and caudal shift, ancus, parahippocampus, gyrus, and temporal lobe, beyond to cerebelli, asymmetrical prepontile cistern, CB angle also wider on the side of the lesion, also affected the trajectory of the posterocerebral artery, become and a anterior communicated artery. Also, this ascending transtentorial herniation noted in this case as cranial shift, part of the subarachnoid cerebellar herniated through the tentorial insurer, compress the superior cerebellar and firmus cistern, and also obturated the fourth ventricle, not seen and compressed by ankle herniation, by transtentorial herniation. Tonsillar herniation also important. This is MRI. This is the tonsil, and there is tonsillar herniation. The normal in the foramen magnum about 3 millimeter. If more than 3 millimeter, it is herniated, causing problem, headache, and sometimes hydrocephalus of the patient. Also, there is important to know external herniation. when post-operative intervention to evacuate bleeding of the patient, even intracranial, intra-axial or extra-axial hemorrhage, the brain parenchyma defect and herniated, the brain parenchyma herniated the defect of the site of operation. So it is called external herniation. Duret hemorrhage also important. Duret hemorrhage is the small linear hemorrhage or area of bleeding noted in the midbrain and upper bones of the brainstem. It is called Duret hemorrhage. Pneumocephalus also important, post-traumatic patient. You can see in X-ray, this is black area, so this is air in the cranium. In bone window also, this is fracture, and this is multiple fracture noted, and this is air loculated beneath the fracture area. It is called pneumocephalus. Pneumocephalus, this is tension pneumo. As you know, there is tension pneumothorax. Also, there is tension pneumocephalus or cephali. Tension pneumocephalus bilateral and compress the both gyra of the frontal lobes. It is called Fugi sign. This is sign is called Fugi sign. Intracranial foreign bodies like this, some instruments, some stabbing wound like knife, like anything penetrating the brain, causing uh, hemorrhage in the patient, intracerebral hemorrhage as a result of a stab wound. As you see, this is the wound penetrating from the parietal to the other parietal, from the right to the left, causing hemorrhagic inside or surrounding the object. And this hemorrhage extends to the ventricle, anterior and posterior horn of the ventricle. Concluding, CT primary modality of the head trauma enough for most part skull X-ray still used in penetrating trauma, suspected child abuse, MRI to help predicting prognosis by detection of subtle injuries, contusion and diffuse axonal injury, primary and secondary lesion, often secondary lesion more important, while checking the scan, making sure to think patient need CTA or other CT, cervical spine, facial bone, any case of trauma, you can take primarily head with the mandible or to include the facial bones. If any facial fracture, nasal fracture, sinus fracture, frontal, maxillary, ethmoid, any facial fracture, you comment in the report, not just comment on the brain only. Also, but or make 3D. 3D is full help in traumatic patient if in fighting or RTA or fall down. Cobb counter mechanism help confirm the nature of acute trauma and search for subtle lesion. Thank you so much for you.
Thank you, Dr. Hussein. Barakallah feek. Now it's the time to give the audience space to ask their questions.
Yeah. هو الموضوع بصراحة دسم شوية لكن شايف يسأل I am general practitioner seeking website or application to help me practice interpreting scans? What should you recommend? Nice question. بصراحة يعني في application CT in the Android or in Apple. There is application name of this application CT scan. CT scan all cases noted in this application. Also, Radiopedia found. I will show the reference now. You can see the reference. This is the reference. The best reference, Radiopedia. Radiopedia, more than 10,000 or 30,000, more than 30,000 cases in Radiopedia. Different cases, all the trauma and tumor, anything you want seen in Radiopedia. So you can searching in Radiopedia and applied CT in application. Okay. Also MRI application found in Android, covering a lot of cases. There is other questions say how to measuring the epidural hematoma and what is the important. Yes, I mentioned it in this question answered in the lecture. The volume is important. You measure volume and measure the thickness of the proximal thickness of the epidural and the midline shift. This is important and put them in the report to help the neurosurgeon for management if need this patient needs surgery if the volume more than 30 cubic centimeter for surgery. Less than the surgeon go to the Glasgow scale if less than 8 and go to the midline shift for report less than 5 millimeter and volume. This is important to and benefit for your patient and benefit for and how to measure the length put a measurement and the depth perpendicular B line on the A and count the slice from the last up to the from posterior beginning and the last cut. When this appear, this hematoma, and count 1, 2, 3 slice. When the finish, there is 32 or 52 like this. Change the slice thickness of the machine. 1.1 measuring multiply by this counting to change from milli to the centimeter to because the volume not by milli, so by cubic centimeter and divide multiplied A by B by C divided on 2. The result is the volume of your collection of epidural hematoma. Inshallah akong jawab ko isa. Also, there is other question. Axonal injury, I have not seen in CT. What I make a report, normal report, make normal report, but make recommendation. In the conclusion, but there are no intracranial acute hemorrhage detected. Patient for MRI to rule out diffuse axonal injury. كيف قلت كده أنا؟ لأنه عندي traumatic patient unconscious، يعني المريض عندي منوم في الطوارئ، يعني في الطوارئ موجود وجابوا للسي تي شايفه no any response unconscious patient brain normal so there is axonal diffuse injury diffuse axonal diffuse brain injury not seen in CT about 65%, so immediately for MRI. There is question, what is the most critical first hour intervention that significant improve outcome in severe brain trauma? When critical first hour intervention for radiological, you have a criteria for report. The criteria, the urgent case, 30 minutes. The inpatient, 24 hours. The outcome, patient and from the clinic, 48 hours. So if you put or write the report immediately, less than 30 minutes, it is important to for your patient. So any RTA is critical. The first hour is the golden hour to يعني لأجل تنقذ الأيان ومن أحيا فكأنما أحيا الناس جميعا. أتمنى أن أنا جاوبت على السؤال إن شاء الله. بعد الانترفنشن ده حق النيور سيرجري يعتمد على الكولكشن يعني immediately when there is epidural hematoma or compressed brain parenchyma evacuated at the same time to 5 hours patient enter the OR. خلصت الأسئلة أظن ما في أي سؤال. No questions. بصراحة الموضوع ده يعني مهم جدا، يعني المفروض أي ريزيدنت بيكون عارف يعني السي تي برين إذا في بليدنج الانفاكشن الحاجات دي المفروض أي ريزيدنت يعرف. يعني المحاضرة دي إن شاء الله تكون غطت مواضيع كثيرة أو بداية يعني الانطلاق إن شاء الله.
طيب جزاك الله خير دكتور حسين، ما قصرت، بارك الله فيكم، أسأل الله أن ينفع بكم وبعلمكم. شكرا زملائنا الأفاضل على حضوركم وتفاعلكم. وفي الختام أود أن أذكر الأخوة الحضور بضرورة تقييم اللقاء من خلال الرابط الظاهر أمامكم على الشات بوكس. دمتم في حفظ الله ورعايته.
شكرا، بارك الله فيك، جزاك الله خير.